Good afternoon and welcome. Thank you all for joining us today. I'm Samantha Mokas and I'm the director of the Florida Association of ACOs. We are excited for this opportunity to present to you the next installment of our free webinar series. Today, we're discussing the innovative methods for data sharing to meet challenges of value-based care. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You should see an attendee interface on your computer desk in the upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during this presentation. We will collect these and address them during the question and answer session at the end of today's presentation. As you all know, Florida Association has been an association for going on 6 years. This year, we are proud to announce we are doing a virtual conference. As you all know, we've been doing one in person for 5 years, but unfortunately, due to COVID, we've made that decision to move virtual. So look for more information on how you can join for our conference dates that are November 18th and 19th. And with that, I'm going to turn the presentation over to Jeanette. She is the Business Development Manager from eMedApps.
Thanks so much, Samantha. Appreciate this opportunity to meet with all the FLAACOS members today, and hello and welcome to everyone. I just hope if anyone is being affected by Hurricane Sally that it passes by you very quickly and everyone stays safe. Vic and Ed have put together a great program today, so let me introduce everyone to today's presenters and tell you a little bit about the companies they're with. So Northern Physicians Organization, or NPO, is one of Michigan's largest physicians organizations. They own both a clinically integrated network and an ACO. Ed Worthington is the director of IT at NPO, and he spearheaded their successful health information exchange, interoperability initiatives, and security efforts. Prior to his tenure at NPO, he spent 9 years working in a variety of capacities at a regional health system. Ed led the technical IT project management and solution development for the Northern Region Shire, and that project was conducted under CMS's state innovation model. As a speaker, he's presented topics related to analytics implementations, health information exchanges, and payer reporting. And today's other presenter is Vic Shashadri. Both Vic and myself, Jeanette Kepasek from eMedApps, are from eMedApps, and eMedApps is a healthcare information technology services company. We work with a variety of healthcare clients across the U.S., and we offer a full range of services as well as a suite of products. Vic is the VP of Product Management and leads all product development initiatives for eMedApps. He is also the chief architect of our care connectivity platform, and he's been the lead architect in interoperability projects with all different kinds of clients, including IPAs, ACOs, payers, and HIEs. With his extensive experience and knowledge, Vic and his team have created innovative solutions to address some of the toughest challenges facing healthcare communities. With that, let me turn things over to Vic to open our program with some of the challenges being faced today. Vic?
Thanks, Jeanette. So what I'm going to start off talking about today is some of the technical challenges or the interoperability pitfalls in a multi-EHR environment. So in scenarios where I'm dealing with members that have different or disparate EHR systems, what are some of the issues that we run into when trying to integrate data together? Just thought I'd start off with a schematic of what a connected multi-EHR environment might look like. So for those of you that have dealt with different EHR vendors and different systems, this will ring true to you. There's no one solution that kind of works for everybody. You're kind of piecemealing it together, dealing with whatever you can to make it happen and put the solution together. So I thought I'd start by first talking about technology in general in terms of this integration. between the systems and what we're seeing as the methodologies that are being used in practice today. First, we'll start by talking about APIs. Finally, talking about APIs in healthcare. With the advent of FHIR, some of the meaningful use MIPS MACRA inspired requirements have brought APIs to a reality in the healthcare environment. All certified vendors are offering some variant of a API that can be used to gather information at minimum, and in some cases, post information back to the EHR vendors. The advantage of these APIs is they're web services based, so they solve the problem of dealing with entities that are outside my four walls rather easily. It's built right into the transmission protocol and allows us to communicate and get information from disparate areas. Another one of the advantages, it's a single implementation per EHR vendor. So once I connect to Allscripts, I can very easily add more Allscripts EMR clients to my solution and be able to get information from there without much difficulty at all. The con for the APIs at this point is there's no standardization across the vendors. With FHIR, a lot of the vendors provide a patient-facing API that's FHIR-based, where you do have some standardization in terms of the FHIR objects that are being used. But in a lot of cases, in order to do what needs to happen, you have to use vendor-specific API methods, and those are going to vary from vendor to vendor. So once I've connected Allscripts and I need to bring Epic on board, it's a rebuild on my part to connect to them and use the appropriate methods that they expose in their setup. In terms of costs, this one is really way out there still. It's relatively new, and so vendors are trying to figure out their pricing models, and some have changed pricing models as they've gone along. But generally what we're seeing is the pricing models fall into two categories. What I like to call app-based fees, which are basically costs to connect an application to the API. So if you've got a third-party application that wants to leverage the API, the vendors have a channel to be able to do that. It often involves some sort of a revenue share with a third-party vendor in order to bring those APIs and be able to connect to their clients. The other area are transaction-based fees. So as you use the API, for every call that's made, there's a fee that's generated, or you buy API calls in buckets. So for the first 10,000 API calls, a certain price is associated with that. The other side of the house, still using HL7, traditional HL7 interfaces. I think the pro here is that it's pretty common industry-wide support for this technology. Every vendor has some sort of an implementation of HL7, so there's really no chance of running into a vendor where you can't get data via HL7. Still some variability between vendors in terms of how robust their implementations are, but at least it's a bare minimum to get you in the door. In terms of cons, with HL7, you have to add connectivity for every site. So even if I have my one Allscripts client and I want to connect a second Allscripts client, I have to go through the same process again with that second client, and then the third and then the fourth. You will have to generate additional interfaces for each site that you add on. And that has a direct impact on the costs. It's usually a repeated cost per implementation. There's not much of an economy of scale that you can gather from traditional HL7 implementations. Vendors will work with you if you're buying multiple interfaces at the same time, but it's not a dramatic reduction on pricing from what their normal single interface costs are. So although it gets you in the door quickly, you have a pretty good chance that the vendor is going to be able to support it. When it comes to growing, it can be quite expensive to take this route. Once you've got the technology figured out, there's still a couple of areas that you're going to run into challenges when you try to integrate this data from multiple sources. The first is a very common one, is patient matching. As you have these silos of data with their own demographic implementations, you're going to run into an issue of trying to determine who John Smith is across all of these practices. Generally, there's a lack of a unique identifier in most areas when you're trying to do this. If you rely on demographic matching alone, it's often not enough. You'll end up with duplicates, or you end up with matching the wrong patients together. And MPI systems are quite expensive. So really, this becomes a very big bottleneck in trying to deploy a multi-EHR environment. The other area is in the variability of the data. So I'm able to connect via either the API or HL7, and when I query and get information, or I'm getting it pushed to me, I see differences in the data that I'm getting based on the vendor that's sending it to me. Structured data is different terminology, different vocabularies that are being used, as well as variability in implementation. So from a CCDA perspective, when I'm getting this data from different vendors, one vendor may put information in the machine readable section, another vendor may put it in the human readable section with a reference to it in the machine readable section. So these implementations will vary from vendor to vendor, and you'll have to deal with that accordingly. So once you've got your technology and you're able to overcome these hurdles, Ed's going to talk a little bit about the solutions that are available today.
Thank you. The first, probably obvious solution that people have been talking about for a while and has been used extensively are health information exchanges. And there are many pros to them. Where they're implemented, especially with significant breadth and depth, so that there's a lot of hospital systems that are on board in a given region, and you also have a lot of your ambulatory and independent practices sharing data with health information exchange. They do provide a nice single source of a lot of data. So it, in a way, acts as an intermediary that solves some of the problems that Vic was talking about, especially with HL7 and scaling data, because you basically have one source for a lot of data if they're willing to send it to you. It also meets the exchange of data, MIPS, meaningful use measures and requirements, which is always helpful for people. But there are some downsides to them, to the health information exchanges. One, not everyone has access to the same level of service, even within a state. If a state has, one health information exchange, it may be poorly implemented in one region, and so those providers and users and ACOs are left out of the benefits of them. The other thing is that many times health information exchanges to establish their relevance, to keep people engaged, or even to continue to provide sustainable financing for their business models, require to use their products. So maybe have like a longitudinal record or a notification service, or they'll contract with another company to implement one of those. And that often requires providers and practices to break out of their existing workflows to search for data that may or may not be there. For instance, if a patient went to a specialist, went to a hospital, the users may not know whether or not that facility or clinic is connected to the health information exchange. So they're breaking out of their work patterns, and they're going to search for this data, and there's a chance that it might not be there. And so they've spent quite a bit of time. They're frustrated, and it generally is a great way to collect information, but it's not a great way to distribute information. Next slide. Direct trust. I think in an ideal world, if everyone knew what was going on in the future, direct trust would probably be a great way to distribute data. And I will say, if you are sending a referral or closing the loop on a referral, direct trust works really well. You know who you're sending it to. The primary care is sending a referral to a specialist. The specialist got the referral and is sending back the note. The problem is that that's not obviously a lot of the scenarios that people seeking data are trying to control for and establish data sharing in. If a patient shows up in the ER or a hospital, or they're out of their area, let's say, in the case of Florida, they live, part of the year in a colder area, They have providers also down in Florida. They have providers where they also, in the other area where they live. Knowing who to send data to, when to send it, where, and where, which direct trust address. It's very common, especially where health information exchanges are established or providers work at multiple facilities. Let's say it's contracted with a hospital and they have their own clinic, they have multiple direct addresses. It's very difficult to know when and where to send. In addition to that, it's not implemented consistently across EHRs. So if you get, and usually a CCDA with some other attachments are sent through direct trust, your EMR may or may not be able to import many sections of that. Most can do things such as meds, allergies, and problem lists, as that was part of the certification. But if you have all of that other information, immunizations, procedures, labs, depending on which EMR you chose, you may have to manually enter those or kind of reference them from your patient documents and not have that part of your workflow. And you have to remember to look for that if you're doing test tracking or any other kind of workflow within a primary care practice. Next slide. Consent. And so I think anyone that's had to think about consent, whether it's consent to share general medical records, consent to share substance abuse information, consent to share other psychiatric information, psychotherapy notes, can kind of appreciate that diagram of trying to figure out, what am I supposed to do? What am I allowed to do? When do I have to do it? All of those questions. And so it's very difficult to track consent. You can easily track within your own practice what consents you have to share information. But when you're thinking about electronic data sharing, there's a lot more to it. There's, did that person consent to share records to you from other practices? If you're thinking about being part of a larger organization or being part of a health information exchange, how do you know if that patient updated their consent? And this is just talking about general, consent as a general concept for sharing records. There are also issues around different data sources and even different parts of data. So, like I said, referencing back to behavioral health information and trying to manage that in our current environment with things like direct trust, it's very difficult and almost impossible to do so at the level that I think everyone would want to do to allow the patients to have more agency over that area. And while HIEs do a pretty good job of kind of acting as a gatekeeper for some consent, between the limitations of what an HIE can do and the limitations of what EMRs can receive and process, they just can at this point distribute that consent well. Next slide. This is an interesting JAMA study we found, and it kind of helps us dovetail into other parts of our presentation that when we're thinking about this disparate EMR environment and the challenges that ACOs especially have, doctors that are in affiliated health systems, where in many cases we can presume they have, they have one EMR, Epic or Cerner, or maybe they have two, or three, but they have a very consistent environment, and they basically have their own kind of unified record. They tend to have higher MIPS scores, while there's no direct causation for what reasons have caused that. Certainly I think that anyone that's worked with independent practices and appreciates the frustrations they have with getting information, getting specialist notes back, et cetera, can kind of see where, providers aligned directly with health systems can have an advantage there. And that it would be beneficial as we're looking at more and more contracts for providers that are both risk-based and quality-based to establish some equal footing so that independent-minded practices and independent focused organizations like ACOs and clinically integrated networks can have the same level of ability and not leave that as a competitive advantage for health system practices and providers. Next slide. And so when we were and just some background, in addition to work with Northern Physicians Organization, they have over time managed two different ACOs that were almost entirely independent. We have had hospitals involved as well. But seeing this in the field and seeing these challenges, eMedApps and Northern Physicians Organization, looked at how can we develop a solution that solves these problems. And the one thing we did was we started from the workflow. We talked to providers, we spent time with providers in their practice, and we looked at, okay, how do you actually work with data? How do you get data? When do you seek to get data? When do you need to have it? What processes could be more efficient if you had data at different levels and presented in different manners? And that informed the technology solution that we put together, with the goal of getting that outcome so that these providers that are part of ACOs and CINs and other organizations can have improved outcomes, improved patient satisfaction, so that providers and clinic staff can spend more time, focusing on patient care and customer service and less on record retrieving and things that we know that are problems that we shouldn't have. And so we looked at, how can we, get rid of those, or get rid of as much as possible those problems, so that providers, which are businesses providing healthcare services, can focus on that core business rather than on data and paper gathering. Next slide. So, like I said before, it's not just about technology. And I would say at the root, it's not about technology. It's about how practices work with technology. So a lot of times, coming from a technology background, I've been guilty of this as well. We see a problem, we're like, oh, technology is the solution. This is a technological problem. But really, it's a problem and an issue with how practices and providers are able to work with data, and what kind of compensating steps they have to make that may not allow them to provide the level of care and the level of time they want to spend with patients to get around having missing data. And that kind of, like I said, informed our process of creating technology that complements the workflow, that's workflow driven and derived out of the workflow, rather than building technological solution that says, hey, great, we have this great product. Now change everything you're doing so you can use this product optimally. We wanted to step in because we feel at the end of the day, practices and clinic staff know how they want to and know how to take care of patients and how to work with the information. They just, they haven't been well served in ways of transmitting that information and doing the work that they know that they want to do with that information. Next slide. And so this is where we thought, and we spent a lot of time talking with practices, physicians, care managers, referral coordinators. What kind of data do you need to do your job as to the level that you want to do it and you need to do it? Regardless of the size of the practice, regardless of the EHR that either themselves or their the rest of the care teams on, they need to have comprehensive patient data. They need to have it quickly, and they need to have it, ideally, when they're making clinical decisions, not having to get it and then make clinical decisions afterwards. We also spend a lot of time looking at other data outside of the normal clinic setting that's important to patient care. So we're looking at, skilled nursing home facilities, home health agencies, especially in many areas they're providing more and more care to patients, as we're trying to do work to keep patients out of hospitals and keep patients out of SNFs, to allow ACOs to be more effective and to achieve better shared savings and to improve patients' quality of life. Behavioral health services, social services. I think everyone on this call has heard social determinants of health a million times, probably. And paramedic services, because there are many cases where that paramedic is kind of the first face of that patient, and having data and transmitting data can be a way to help that paramedic, maybe not the paramedic themselves, but in communication with other parties, provide the care that's needed at that site, rather than bringing the patient into an ER and leading to an inappropriate admission. The other area was real-time data and the ability to get ahead of the patient almost. And that's where it's not just the data that matters. It's when you get it and when you can make decisions on it. So ADTs, not just concentrating on discharge ADTs, which are great for reporting and doing retrospective analysis and maybe calling the patient in to schedule an appointment sooner than you would otherwise. But seeing the patient when they're admitted, seeing that journey through the health system, to see if there are places where the practice, the providers, care managers can intervene to maybe prevent an ER visit from turning into an inpatient, or to otherwise try to reduce the amount of time that patient spends in the hospital so that they're getting the care they need, but they're not getting duplicative care or unnecessary care. Driving the access to data around patient appointments rather than just having this large repository where it's like a big daunting library and you have to go to the card catalog to figure out what you're looking for. Instead, saying you're driven in many cases by your daily schedule, and driving access to data and aligning it with the schedule and the practice so that they can see that patient throughout the community, throughout the care they're receiving, but they don't have to spend time searching for what they need. The other ability is to communicate with other providers within an ACO or other CIN or other organization, but not just send communication like you see with some of the HIPAA compliant texting solutions or whatnot that's available, but add context to that message with clinical data. So you could take a piece, the ideal solution is you're looking at a chart, you need some clarification on a medical decision or a medication or an allergy or something, using that piece of information to drive the communication to the third party so that there's context and you're not spending a lot of time, scanning a document or taking a picture or uploading it. Just acting right when you see the data so that it's done quickly and you get an answer back sooner. Next slide. So the key features of the solution that we developed that Vic will be demoing very soon here, it was built around a couple principles. One, that the patient is the steward and in control of their consent, and that they have multiple consent options. The patient needs to be engaged with sharing their information, and as more and more areas of people's lives, like behavioral health, social services, social determinants of health, become part of, integrated with health, patients are going to want to have more trust in the data they share and have more control over it so they feel comfortable doing so. I think everyone would hope that patients are comfortable sharing information with their medical providers, but I think we all know that anyone who's spent time with practices knows that they don't always. So, providing them with that control helps them trust more in their sharing because they can control whether or not they have to share or revoke their consent, and they don't have to do it in a really painful, painstaking, work-intensive manner. As we've referenced previously, eliminating the need to search for patients. Instead of logging into a tool with a search box or just a list of all the patients that are possibly attributed to a provider or practice, logging in and seeing your schedule. That's what you're working on today most of the time. That's where most of the time you're going to want to see data. So starting from that point and having the data that you need is attached to that schedule so you can look at it either prior to the visit or during the visit. And aggregating the data in a manner that, and providing options in how you view the data when you aggregate it. So providing a timeline view where you could see data chronologically, so you could watch the health status of that patient over time change, or in a longitudinal format, which is the normal note that all of us have seen and usually you would see in an HIE. Like I said, the ability to send messages to groups of individuals, like a care management group or to a practice or to another team, with data attached to it, so that messaging process, everyone can see what information is needed, what everyone's referring to, and people don't have to spend time duplicating that information and creating, essentially within a product, an awful email chain that, makes it inefficient in other areas and would be absolutely awful when trying to coordinate information sharing for caring for a patient. And ADT notifications. I think anyone that's worked with ADT notifications knows how powerful they can be within a practice when they're done right and when they're implemented in a way that makes them usable. So seeing that the patient's been to the ER or to a hospital before the visit and not dependent on waiting for the hospital to fax information, which could be, depending on the hospital, days afterwards. So seeing that information happened, that event happened, or seeing right when that event happened so you could reach out. And putting all of that in a package that is built around what happens in a practice and not just in a large kind of repository that you have to dig around in. Next slide. Okay, and now I'm going to turn it back to Vic, who's going to show you some of the key features and how Community Health Cloud, the product, works.
Thanks, Ed. So I'm going to run through a quick demonstration here. Let me switch to the actual application. And what I'm going to do is I'm going to kind of show you the workflow and the view from both a care coordinator's perspective as well as a patient's perspective. So the first thing I'm going to do is log into the Community Health Cloud as a care coordinator. And as Ed talked about, the entire experience is driven from a workflow-based model. So we bring you right into what we call our notifications. So these are the things that should be of interest to me as a care coordinator in this practice. So appointments that are there for patients, notifications that have come in either automatically generated based on events that have occurred outside of your health organization, or manually sent notifications. So as I talked about on the previous slide, I've got a lab result that came into me as the primary care provider, and it's something that I want to make the patient's cardiologist aware of. So I've notified the cardiologist of this particular lab result. So that would also show up in this workflow for them to be able to deal with. What they're going to see is information about the message that came in, some details about it. They're going to be able to look at consent information for that patient as it relates to their organization, as well as the attribution of that patient from their care team. So who are all of the members of this patient's care team? They can pull up and look at all of that data. The list is filterable, if I can say that. You can define and create as many filters as you want. So for example, I've got filters here created for my hospitalization. So I can click on that and it'll very quickly take me in and show me all of the hospitalizations that are of interest to me. For the hospitalizations themselves, I'm going to see those admits that Ed talked about, observations. I'm going to see discharges. I'm going to see transfers. So if that patient came into the ER and then got transferred to the inpatient setting, I'm going to be able to see that transfer occur. So you're not waiting for that discharge to happen before your clinic starts to take action on it and your care coordinators start working on it. For the appointments, I'm going to be able to see my patients that are scheduled in my system, so I know who's coming in. Depending on how you do your pre-visit planning, you can control how much of the data is visible at any given time. Do I want 3 days worth of appointments visible, 2 days, 1 day, whatever makes sense for the organization. So this kind of becomes your starting point where you can then drill in and get into the details of the information associated with that patient. As Ed talked about, we have two different views of the clinical information. I'm going to start with our timeline view, which allows me to come in and look at this patient's health history over time. It'll default into the current 3 months, so I can see what's happening with that patient right now, or I have the ability to change my time frame and look at different clinically relevant time frames around that patient. I'm going to go ahead and pull open the patient's entire history. And what you see here is a graphical representation of what's going on with this patient. You'll see their immunizations, their medications, allergies, problems, procedures, results, hospitalizations, any social history that's been captured, and vitals information across time. You have the ability to scroll through the timeline if you'd like to. You can zoom in to specific areas. So if I wanted to see what happened in January of 2016, I could zoom right in and I'd get a much more granular representation of what occurred there. I can click on any given item and see details of the associated event that occurred there. So in this case, an immunization. If I wanted to pull up a medication, I could pull up a medication and get some details on that medication that was prescribed there. With all of the clinical data elements, you have the ability to send notifications to the patient's care team. So if I wanted to make someone aware of this medication, I could click on the little notification icon here and generate a notification for that other user to be aware of this medication that occurred on the patient. The other view that we have is sort of the more traditional HIE type view, which is a longitudinal view of the information. On the home page, you'll be able to see the entire CCDA history of that patient, where all CCDAs have come from. You can actually view the CCDA themselves. You'll see any appointments that they have coming up, or in the past. You can filter by that, as well as their care team and their visit metrics. What we mean by the visit metrics is their hospitalization metrics. So where have they been in the past 6 months? where have they been in the past year. And then at the top of the page, you can drill into multiple different clinical data elements. So for example, if I wanted to look at the inactive medications on this patient, I could drill in and look at the inactive medications, and I'd see a chronologically descending history of all the medications that this patient has had. Lab results are available. Depending on the data source, we get radiology information, things like that as well. Vitals, immunizations, procedures, social history, hospitalizations, providers, and problems. All of that data is available to the care coordinators in your environment, so they can go in and look at this detail driven from that notification that they received about this patient. I'm going to go ahead and log out now and give you a view from the patient's perspective. So I'm going to log back into the system here, but now as a patient. So as Ed talked about, the patient drives the consent for what other users in the system are able to see. When the patient logs in, they're directly taken to their consent page where they have a list of all the data contributors that are contributing data on that patient. They have the ability to, at the level of each data source, determine consent of what happens to that data. So is that data, can I share that data with other members of my care team or not? And then they have the ability to define a default consent. So they can tie in a default consent of what they want to happen with data that comes in where consent hasn't been defined yet. So they can either, this is like an opt-in or an opt-out. They could opt in and say, I automatically want to share everything that comes in with my entire care team, or I don't want to share everything, and then I want to be able to select and control that myself at a source by source level. The other things the patients get, which our users really love, is the ability to see all of their own data. So they have access to the same timeline and longitudinal views that the providers have. They can see the information here. They can go into each of the sections that the provider organization did. In fact, their view is a complete view of the data, whereas the clinician's views are going to be based on the patient consent and how they've defined their consent around there. And finally, the patients have the ability to go in and look at how their data is being used. So they can come in and see exactly what's going on with their data in their environment, who has accessed my information, and what have they done with my data. So that information is available to them. They have the ability to see that, so they know how their data is, who's consuming their data within the organization. I'm going to jump back here to the presentation. And so how does this tool affected or benefited organizations that are using it? So I'm going to spend a couple of minutes here talking about a case study of an organization that's using Community Health Cloud. It's a physician organization comprised of both primary care providers as well as specialists. It is a multi-EHR environment. The providers that make up this physician organization use 6 different EHR systems, and the number of sources that are contributing data for this implementation, there are about 245 separate data sources that are coming in. That includes the 33 physician practices that are part of the physician organization, but it also includes a number of other organizations in the community, including the hospitals, the emergency rooms, as well as some of the other organizations that Ed talked about, SNFs and other things of that sort that are contributing data into the Community Health Cloud. This particular organization has 546 clinical users that are using the system. 74 of them are providers. 472 are clinical support staff or care coordinators that are accessing clinical information, the notification lists that we talked about. And there are over 16,000 patients that are registered users of the cloud within this deployment that are actively managing their consent, and they're able to look at their information and see the usage of their information from within the cloud. Currently, they've processed in excess of 2 million CCDAs on these patients and aggregated the data across the patient population there. So what are some of the results that we've seen? The first one that was very important to the organization that hit them directly on their bottom line is they were eligible and were awarded a $250,000 grant for having a comprehensive consolidated community-wide patient record. So based on the number of sources of data that were coming in, the fact that we were bringing in data from all 33 of those organizations, from those 6 different EMRs, and we're able to aggregate it together and provide that community-wide patient record, made them eligible to get this. They were able to reduce emergency visits by identifying missed interventions, reduce costs by reducing duplicate diagnostic efforts, and they were able to streamline their workflow by eliminating some of the manual processes in their care coordination, with their users having to track down data and figure out where this patient has been and get information from those organizations and make it available to the practice. A quote from one of the users in the system: CHC takes ADTs a step farther by allowing us to dive further into the patient records. Some services offer alerts, but CHC offers more robust data behind the alerts. So the ability to use the alert and the notification as the beginning point of your workflow and to dive into the details of the data, really beneficial from a clinical point of view. Oops, I clicked the wrong button there. Okay, I'm going to have Ed take over again here so he can talk about some of the benefits. Ed, go ahead.
Okay, thanks. All right, next slide. Okay, for providers, what we found with, like in the case study with users, is that it helps support the type of delivery of care that they hope to provide and they want to provide for their patients. They're able to have a holistic view of the patient and seeing this aggregated information. And at the point of care, they have the actual insights they need to help inform their decision making. They're not just looking at old data. They can, they might see a visit from a specialist that happened, a day ago or even earlier in the day. That information is available and it's usable immediately after it's created. By having one unified record that the entire care team can look at, for those patients that have chronic illness or otherwise high cost or complex, having that unified record that everyone can look at, work from, communicate from, helps manage that patient better. And the fact that it's, as we'll talk about next slide, how the fact that the patient also has access to that record helps keep that patient engaged in their care, and which is a vital portion of having effective chronic care management, is that patient decision making and patient engagement. It helps streamline visits. Providers can see more patients per day because, and all that time that has to be built in to hunt for information and to prep for visits is streamlined because the data is right there. It's viewable in the form of your schedule and can be used immediately. And so we can prevent the days when you're having to run around with the copiers or dig around through a scanned documents folder that's enormous inside of an EMR to look for a note that happened or to check to see if something came in through direct trust previously the day before and you missed it, etc. Next slide. And patients, it helps improve the discussion between patients and doctors. Those patients that consented that are actively managing their information, and when Vic was talking about the case study, they have access to their whole story. They can share it. They can reference it. They know what their provider is also looking at. So, and it helps them have confidence to ask questions about their medical history, their medical status, their test results. And it's done in a unified manner. They don't have, if it's a patient that, has a lot going on, they don't have 15 portals to log in or anything like that. They don't have to carry around a big binder. I think anyone that's worked in patient care knows that, there's some patients for a variety of reasons that have to have seems like they have to carry around an office with them. Additionally, they don't have to tell their story over and over again. I think a lot of patients, and I've experienced that with family, you feel like you're almost playing that old phone game when you have something going on and you have to tell multiple providers and clinical staff the same story over and over again, and you're bound to miss things. Not because you want to hide them, but just things get missed from saying the same thing over and over again. So not having to do that or bring your med bags is beneficial for that patient. They can look at their record for reference for themselves, or the provider's access to record directly. They have really effortless. Vic showed how easy it is to control access to their information and to see who's looking at it, which like I said, with some of that more sensitive information, and as more areas of people's lives are getting integrated with health data, helps them have confidence in knowing that their data is used appropriately and that they have some, control over that. The fact that providers can help proactively avoid unnecessary hospitalizations, ER visits, medication complications by having access to this shared record improves the quality of life for the patient. I think nobody wants to keep staying in the medical system, and keep getting health care. They want the amount of health care that they need to have the quality of life that they want. And so the shared record, and an actionable shared record, helps them get that appropriate level of care they need and want, so that they can go on with all the other things in their life they'd rather be doing. Next slide. And care managers, the first thing is that consent discussion really becomes an opportunity to talk to patients about engagement. They have a question about it. They're looking at their record. They're asking questions about their record, even if they've already consented, and it helps start that conversation with the care manager, and helps the patient become more involved with their care, just by having that information available and having control over it. Because we're eliminating and all of those extra, workflow steps that people have to go through now in practices to compensate for data that's not readily available and when organized in an effective manner. We're helping care managers and others, practice at the top of their license and to their ability by focusing on providing care rather than focusing on, looking for information. By identifying gaps in care, they can coordinate better with, for their patients that they're taking care of, and in communication with the providers to make sure that gaps in care are getting filled, make sure that, you sent the patient, you made a referral to the patient for a colonoscopy to the GI. You could see whether they made that appointment, canceled that appointment, whether it happened. You're not kind of left in the dark waiting for the, fourth quarter, mad dash to try to fill in your HEDIS gaps. You could see this stuff happening throughout the year and seeing if the patients are following up in a much more effective manner than you can now with just relying on your EHR and referral notes coming back. Next slide. So I think when you kind of take a step and abstract what we've talked about out from just the practice, and you're thinking about an ACO, you got to think about some of the components, and these aren't all of them. These are components relative to what we were talking about that can help ACOs meet their goals. We all know them: improved outcomes and quality and greater shared savings. By automating processes and reducing that non-value added work for providers and staff, it gives them more time to do the things that the ACOs want them to do, and the ACO medical directors want them to do. Reduce test duplication, educate the patients on evidence-based care guidelines, talk to the patients about, actually adhering to their care plan, in all of those different areas. They can spend more time with the patient, having those discussions, figuring out the barriers, breaking through the barriers, and ultimately getting the outcomes they need. And that leads to that, that helps inform and assist care managers and others in the team with coordinating the care for the patient. They can message in real time with clinical data. They can see real-time ADT as the hospital stay and hospital or ER event is happening. And they can view appointments, in and outside of their practice, so they could see, like I said, okay, I told that patient to go, that they needed to go get their retinal eye exam because they're diabetic, and it's been, a year, and they're due for a new one, a year or two. They could see, okay, they made the appointment with the ophthalmologist. They saw the appointment, either I already have a CCD back that I can reference to see the results, or I know, to expect the note. And that helps keep everyone involved, coordinated, on the same page with the patient's care. And when you think about all of those improvements, while they're not the only solution, or they're a significant part of what can help ACOs, reach those goals of greater shared savings and improved patient outcomes. So when we were putting these slides together, we were kind of thinking about, how to illustrate that. And anyone here that's of a certain age has seen a reference either on the internet or, watching a South Park. And so we kind of think of our solution as the phase 2 for the underpants gnomes. And, it's filling in that missing gap that everyone knows needs to be filled. But all the good and hard work that everyone's been doing to try to fill those gaps has been, not done in a way that puts all the pieces together. And when we were, working with the practices and the ACOs on their workflow and what's going on, we decided that, our best and impact in that whole process would be to positively fill those gaps so that the workflow can be more effective. Next slide.
Okay, so I think it's time to open the floor for any questions.
Yes, we do have a few questions. The first one, for networks that already have a longitudinal record in place, how could the network benefit from the Community Health Cloud? Has the product been deployed in a pediatric network only yet? If so, how do you handle consent for patients who are minors with potentially multiple guardians?
Do you want to go first on that?
Yeah, I'll start with the last question first because it's fresh in my mind and there's multiple parts to it. We haven't implemented it in a pediatric only network. Having worked with, through pediatric consent processes with minors before, I think one thing that's key is that we developed a very flexible consent model, and that can be adjusted based on both the rules, in the state, because every state has different rules around consent sharing, especially when it's health information exchanges involved, or many do, I should say. And for those circumstances that are more complex, like you said, with the multiple guardians, and it can, during implementation, and we've done this already with in the case study, we adjusted their consent settings to meet their needs. It can easily be adjusted to allow that, let's say, block patients, in some scenarios, and I don't know if this is the same everywhere, but one experience I had was that we had to more proactively have the patient involved once they hit, I think, the age of 13. And so we can put controls and rules around based on the age of the patient, and work with the practices to ensure that the consent process for those younger than that is only offered to the appropriate guardian or guardians. I think the key thing is that we don't automatically and don't link accounts. So a parent, can't, without the proper authorization, a guardian or another parent that's a non-legal guardian parent can't, automatically kind of hijack the account and link it to theirs and then see what's going on, because there are a lot of very delicate situations where that needs to be controlled more. The first question, we actually, the case study wasn't in a state in an environment with a very well-developed HIE, and it provided quite a bit of value. Actually, I think the two in unison and really optimized outcomes for the users, because we were able to more efficiently implement the solution by leveraging the HIE as a data source instead of building interfaces with every hospital or non-hospital provider. Additionally, it complements it because like an HIE, even an HIE with longitudinal record, doesn't really have those workflow triggers and scheduling triggers. They're not even, almost none of them, I can't think of one that's even getting scheduling data to build those triggers around. So I think that it is good. I think having HIE and Community Health Cloud is beneficial because Community Health Cloud can leverage the HIE to be that more effective for the user base in that area.
Yeah, I think I would just add on in terms of the question on consent, that is driven by the clinic organizations with the patient and the parents in the scenario. So as Ed said, the tool supports flexibility in how that's controlled, but at the end of the day, the organizations themselves will work to determine the guardian that would be driving that.
Thank you, Vic. We have time for about one more question. So our organization currently has patients opt out for consent. Would we still be able to utilize CHC since your model has patients controlling the consent process?
Yeah, I can take a first stab at that. So absolutely. So initially, the data that's visible for an organization is data generated from your practice, as well as data that comes through based on hospitalization information and is displayed based on a consent through the hospitalization process. So there is some information available. It may not be a complete view of the patient's record until the patient provides consent, but there is definitely information and things that can be leveraged within the application. So notifications will still come in for hospitalizations and things of that nature.
Great, thank you. Well, with that, we thank eMedApps for taking the time to present this information today, and thank you everyone for participating in today's webinar. Once you exit, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. We will also be sending an email with contact information if you have any follow-up questions and a link to the webinar recording. Please feel free to share this link with anyone you may think may be interested, and watch your emails for upcoming webinar announcements. Thank you again, and have a great day.